Hello everyone, my name is Robert Dang and I'm a second-year medical student at California North State School of Medicine. And today I'll be presenting on high-sensitivity cardiac troponin and its effects on ED length of stay in collaboration with the UC Davis Emergency Department. This research was supported by the UC Davis Collaborative for Diagnostic Innovation, Improving Diagnosis in Healthcare Award, an investigator-initiated grant from Roche Diagnostics, and a grant from the National Heart, Lung, and Blood Institute. Cardiac troponin testing is performed in nearly 1 in 5 emergency department visits in the United States. In 2017, the FDA approved high-sensitivity cardiac troponin assays in the United States. As these assays are being implemented in clinical practice, concerns have been raised about their effects on ED operations, admission rates, downstream testing, and interventions. The objective of the study was to determine the association between implementation of high-sensitivity cardiac troponin assays for 0, 1, and 3-hour testing algorithm and clinical operations in the emergency department. We hypothesized that implementation of high-sensitivity cardiac troponin would be associated with shorter ED length of stay with no change in admission or cardiac diagnostic testing. We performed a prospective observational before and after cohort study in a single urban academic tertiary medical center. Pre-implementation groups was collected from March 12, 2018 to June 15, 2018, while conventional cardiac troponin was used clinically. High-sensitivity cardiac troponin was implemented on June 18, 2018. We allowed a 2-month washout period for providers to acclimate to the new assay. Post-implementation cohort was enrolled from August 20th, 2018 to January 3rd, 2019, while high-sensitivity cardiac troponin was used clinically. ED length of stay was defined as the time from ED arrival to ED departure, and ED length of stay times were log transformed for analysis. Modified heart scores were collected from the treating physician. Admission to hospital or observation unit was also recorded. There were around 42,000 patient encounters during enrollment periods. Around 10,000 encounters had a troponin ordered. We approached around 1,200 patients and enrolled 10,079 patients included in the analysis. In looking at our pre and post implementation cohorts, median age was similar in the two groups. Roughly half of the populations overall in both groups were male, and roughly half of the populations overall in both groups were white. More than twice as many patients in the post-implementation group had a troponin greater than the 99th percentile. More patients in the post-implementation group underwent serial cardiac troponin testing. Median length of stay were 428 minutes and 487 minutes for the pre and post implementation groups respectively. After adjustment with sex and modified heart score, differences were not statistically significant. Admission rates were 51% and 56% for the pre and post implementation groups respectively. After adjustment with sex and modified heart score, differences were not statistically significant. Some limitations for the study were that it was a single center study and results may not be generalizable to other patient populations or other practice patterns. Implementation of a 0, 1, and 3-hour testing algorithm in tandem with implementation of high sensitivity cardiac troponin may confound results. We allowed for a 2-month period after high sensitivity cardiac troponin implementation before beginning enrollment of implementation cohort. More time may have been necessary to realize full effects of high sensitivity cardiac troponin implementation. Time periods were not temporally matched between pre and post implementation groups, introducing a possible source of bias. The data collection period was shorter than international studies that did find changes in these metrics after longer periods of data collection. In summary, implementation of high sensitivity cardiac troponin with a 0, 1, and 3-hour testing algorithm was not associated with changes in ED operation metrics, including ED length of stay and admission rates. Thank you for listening to my presentation. If you have any questions, feel free to direct them to my email or directly to my PI, Dr. Bryn Mumma. Thank you.